My topic about early onset scoliosis with neural axis anomaly and daily management. And neural axis abnormality that are seen together with spinal deformity are aortic malformation, synovial, hydromegalia, low conus tetrapod, intradural mass, extradural mass, and arthritis. As a detailed clinical, neurological, and radiological examination are mandatory for the assessment of neural axis anomaly in early onset scoliosis. These neural axis abnormalities remain undetected. There is severe neurologic risk during deformity correction. Neurological examination should include motor function, sensory function, reflex function, and the rate of neural axis abnormality in patient with infantile or juvenile idiopathic scoliosis with the curve greater than 20 degrees is reported to be approximately 20% by the St. Louis group. More than 50% patients with idiopathic scoliosis have neural axis abnormality on MRI may need neurosurgical intervention between the time of birth and 10 years of age. Screening by whole spine MRI examination recommended in patients with neurological deficit, early onset scoliosis with a curve more than 20 degrees, main gender, presence of abnormal sagittal spine profile, atypical curve shape, especially left side curves, rapid progression, and presence of pain. The incidence of the spinal anomaly, congenital spine deformity is reported between 5 to 58%. Tetrapod cord and diastematomyelia are most common intraspinal anomalies seen with congenital scoliosis. In the assessment of congenital scoliosis, evaluation of neural axis anomaly with MRI is mandatory. The tetrapod cord, back pain, and bladder dysfunction are common symptoms in tetrapod cord syndrome. Tetrapod cord can be asymptomatic, can be operated by prophylactic purposes, and may result in severe neurological deficit. And the sign of tetrapod cord is leg weakness, atrophy, loss of tendon reflexes, sensory loss, progressive scoliosis, equinovarus and equinovalgus. As in the presence of progressive neurologic impairment, surgery is performed in order to prevent iteration, reversal of the symptoms. In patients with pro angle less than 35 degree and tight film, spinal cord untethering may prevent or even reverse scoliosis curve progression. In this patient, untethering procedure should be followed by the observation period. This paper reported by Baylor College group. And some of our cases, 25 degree scoliosis with the synovial and cyclic cord malformation type 2 and tetrapod. Tetrapod release was done in this case. And you can see here follow-up, and her deformity decreased from 25 degree to 20 degree. And there are two types of cord malformation. In type 1 cyclic cord malformation, there is diastematomyelia with two hemichord in double dura and bony or cartilaginous septum. In type 2 cyclic cord malformation, there are two hemichord in single dura and without septum. And type 1 cyclic cord malformation commonly seen with tetrapod anomaly. Any attempt for deformity correction without the treatment of spinal cord malformation may result in neurological deficit. Deformity correction in the presence of the spinal pathology requiring surgical treatment can be done with separate surgery or with simultaneous surgical treatment of deformity and the spinal deformity. Separate surgery recommended by Master and Mark Winter. Neurosurgical and corrective surgery can be done at the same season. We have performing simultaneous surgical treatment of deformity and spinal abnormality since 2002. Our paper, first article in the literature about simultaneous surgical treatment of deformity and spinal deformity. Disadvantages of separate surgery are another surgical procedure, difficult surgery exposure, more bleeding, less clear anatomic landmark, 6 to 8% risk of retettering, increased risk of iatrogenic neural injury, more complicated reconstructive procedure. Surgical technique exposure includes exposure of the terminal level, pedicle screw placement, neurosurgical procedure, instrumentation and corrective surgery, delay anterior surgery if necessary. If pedicle screw placement and neurosurgical procedure takes a long time, corrective growing rod surgery can be done in other settings. You can see she had 3 pelvis surgery, very severe coronal and sagittal imbalance, congenital scoliosis with the split malformation type 1 and tetrachord. And we have performed simultaneous surgical treatment of deformity and spinal abnormality. You can see this postoperative and preoperative X-ray and clinical picture. Now, the other case is 9-year-old idiopathic early onset scoliosis cases and with the tetrachord. We have performed our growing system with the tetrachord release at the same stage. And type 2 split cord malformation there are 2 hemichord in single dura without any symptom. Patient with the split cord malformation type 2 can be operated safely under neuromonitorization without any need for neurosurgical procedure. You can see is 8-year-old is very upper thoracic congenital and thoracolumbar compensatoire severe curve, tip 2, split cord malformation, and we have performed our growing rod system, and after 5th lengthening procedure, we did final surgery in this case. And you can see is we obtain is coronal plane correction 91% and trunk height increase 23% with the growing rod system. And you can see its final X-ray. Last case, there's this very severe congenital scoliosis cases in the diastematomyelite tetrachord and a 2-year-old. And we did is short segment PVCR at the apex of the deformity and the growing rod system and simultaneous surgery at the same stage in this case. Now, patient younger than 10-year-old with idiopathic scoliosis curve greater than 20-degree congenital scoliosis patient with the neurofibromatosis and Marfan syndrome must be evaluated with full spine MRI study for neural axis anomaly evaluation. According to Bailey-Cars study, early onset patients with COP angle less than 35 having tetrachord syndrome with or without neurological impairment should be observed hollow tether release before deformity correction. In the presence of interspinal pathology, the requiring surgical treatment with early onset deformity, neurosurgical and corrective surgery should be done at the same region under neuromonitorization. Patient with split cord malformation type 2 can be operated safely under neuromonitorization without any need for neurosurgical procedure. In the presence of split cord malformation, differentiation of type 1 malformation from type 2 is critical before any surgical attempt. A detailed radiological evaluation must be performed prior to surgery. In suspect cases, myelocity study may be helpful to MRI in differentiation of the malformation. Thank you very much for your attention.
Think about early onset scoliosis, unless someone tells you otherwise, it unfortunately is full of complications. And it's very important to absolutely let your staff or your parents know that that is the case. Those are my disclosures. In terms of complications, this is a high-risk undertaking. A paper published by Jonathan Phillips showed that in those patients, which were the high-risk patients, there was a mortality of 18%, i.e. 5 deaths out of 28 patients. And the deaths were multifactorial, based on etiology, natural history, fragile physiology, the medical morbidities, and in some instances may actually be due to the secondary to surgical intervention. We agreed before that early definitive spinal fusion was unacceptable. However, the 4 to 6 monthly serial distractions means multiple definitive anesthesia. There is the effect of the exposure of the immature brain to anesthetics, and you have the psychological trauma to the entire family, not just the child, the psychosocial challenges, and the behavioral problems that arise from these repeat surgeries. The risk of developing learning disabilities, the hazard ratio is 2.12. The highest risks are children who are aged less than 2 years. Repetitive anesthesia is an independent risk factor after adjusting for health status. And it's time to ask ourselves, is this preventable or is this inevitable? So 12 patients treated with a rib-based system for EOS, behavioral assessment system for children, psychological tool used. 1/4 scored significantly low for at least one domain, and only 42% scored normal for all domains. And therefore, I believe that appropriate counseling should be done to the caregivers. Serial casting, this is changed every 3 monthly intervals, 3 to 6 monthly, has all the risks and complications of repetitive anesthesia, has a pulmonary morbidity despite the fact that no surgery is performed, and in many cases, only a delayed tactic, but effective in idiopathic scoliosis in a particular group of patients treated early. So, casting, we have seen in a JPO publication, 2012, a good pair of and very responsible surgeon, 20% complications, 7 out of 36 patients, all of which are not fatal. The full resolution of the curve, however, in 6 patients, 17%, and however, it did delay the surgery for an average of 2.1 years. Medical complications, pulmonary, at least 50%, can also have complications for gastrointestinal problems, genitourinary, which is dermatological, particularly in patients with latex allergy, cardiac. And again, the key to try to minimize the complications and manage the complications are to have a multidisciplinary approach. Hodgkin's criteria of major and minor complications, you have respiratory depression, aspiration pneumonia, pneumothorax, pleural effusion, respiratory arrest. What else can happen? You can also have the obstruction, we published a paper, obstruction of the right main bronchus, particularly in patients with a lordoscoliosis. And it's important in this situation to correct the restoration of the kyphosis. Complications of halo, which we use very well. We published a series of 4th and 6th cranial nerve palsy after halo traction in children, 2 case reports. However, most of these, well, all of these recover if you treat it early and appropriately. Surgical treatment options. Well, effectively there are 4 that I know of. The growing rods, which can be single or dual, the magnetically driven rods, staples, Vepta, and the Schiller procedure. However, I will only cover complications for each of these individually. So, surgical complications. It's generic to early onset scoliosis irrespective of surgical options chosen. I'm afraid all the options have complications. And the complications, there are nevertheless unique complications to particular operations, for example, growing rods and Vepta. And of course, there are the generic complications, which are the infections, the implant failure, and of course, the proximal junctional kyphosis. So, the complications due to pedicle screws, spinal cord injury, multimodal neural monitoring, SSAP and TCMEPs. The key, of course, is to know anatomy and practice, and the OR may also be useful for some surgeons. The cost in terms of compensation, never mind the complication, is millions following spinal deformity surgery. SSAPs with pedicle screws is important. TCMEP can be used. And of course, normal tension is important, particularly during instrumentation and correction. And again, teamwork and attention to details. You can also have other complications, descending aortic injury due to thoracic pedicle screw insertion. And of course, pneumothorax, congenital injury, pericardial effusion, esophageal injury, all of which has been reported. Pediguard may be of some value. However, the technology can only complement and not be a substitution for technique, and I will urge you to concentrate on technique. So, post-operative infection, we talked about pedicle screws, now it's infection. It's a never event in the NHS unit, significant cost and burden, compromises outcomes, demoralizing to the treating surgeon, and could be fatal. Conventionally, Staph aureus cover is required. In my practice, we do cephalosporins and gentamicin. We see all our patients preoperatively, and now we are trying to customize the prophylaxis for these patients depending on the skin swabs and on the urinary outcomes, and hence move towards individualizing the prophylaxis as opposed to treating them generically. I also now use vancomycin, previously only in adults, but now I use it in kids as well. There are very good complications regarding the safety as well as efficacy of topical vancomycin in these circumstances. It's important to be mindful of the infection rates, SRS, MNM. We have all of this. This is one of the resources we provide to surgeons. 1 to 3% in scoliosis, 5 to 20% neuromuscular scoliosis, highest incidence in spinal dystrophism and myelomeningocele, and in 2 to 4% in congenital scoliosis. So I think, and again, this is a rate of infection. It's a good denominator for your own practice, because this is the rate of infection after surgery based on 108,490 procedures. The current standards of care, again, all of this has been previously published in terms of prepping, in terms of education and so on. All of this is available, and there is a consensus recommendation, particularly for patients in high-risk pediatric spine surgery. The complication scale, case reports, precipitation of cardiac failure following lengthening, history of cardiac rupture, fatality while submuscular insertion of growth rod. The message is, in the presence of kyphosis, do not attempt minimally invasive insertion. Vector complications, again, history of esophageal atresia, rupture following expansion rhodoplasty, other complications, again, very similar to growth rods. The highest incidence of wound is in fact in the Vector group, and the implants are usually inserted subfascially, which allow healing by secondary tension. There's a non-statistical difference between any of these 3 types of construct among growing rod. The hybrid construct seem to have the least number of procedures per patient. So, Vector versus growth rod both have a place in the treatment of early onset scoliosis. Individually treatment based on the merits driven by the clinical needs. Definitive spinal fusion eventually needs to be done in both growth local logistic training and skills are the important factors in minimizing the complications. So the medial migration of the proximal anchors, again a publication of 3 patients. Why has this happened? One common feature is that none of them had transverse process hooks. What I've done is use what I would now call the Taj Mahal construct, which is to have 2 TP hooks based on the outside at the top. And that is based on the fact that minarets have a 7 to 12 degree outward tilt, which is intentional, so that in the event of an earthquake, the central dome is protected, the minarets fall outwards. It actually is an optical illusion because from a distance they're erect. So TP hooks, in my view, apply a laterally directed force so that in the event of screw loosening, they prevent medial migration and compression. So I have also moved on to the magnetic growth rods, and again I summarize this by simply saying that the implant-related complications in terms of screw pull-out and so on are pretty much the same as in the conventional growth rod system, but what is lower is the rate of infection and of course the lack of repeat surgery and therefore the psychological complications that follow up from that. And these are just examples of this. So I'd like to end my talk on that note so to keep in time, and I'd be happy to take any questions that might come in here. Thank you.
Surgical treatment option for early onset scoliosis are broad fracture spine surgery and definitive surgery. Broad fracture spinal surgery the challenges associated with the use of this system include obtaining and maintaining deformity correction and achieving spinal growth, allowing long growth. And broad spinal implants are classified into 3 groups: distraction-based, compression-based, right growth system. And I would like to mention some important points about treatment of early onset scoliosis. First point is the importance of apical and intermediate anchor in treatment of early onset scoliosis. You can see very severe early onset scoliosis with severe thoracic and lumbar kyphosis. We have performed growing rod system in 1997. You can see thoracic kyphosis continue to progress during the follow-up period. There were no anchor intermediate and apical vertebra in the thoracic area. The lumbar curve could be controlled with pedicle screw, thoracic curve would not be controlled, and main curve show progression in this case. This case shows the necessity of apical and intermediate vertebral anchor to control the curve in the treatment of early onset scoliosis. I want to explain second important point. This is 4-year-old. She suffered from thoracic facet fracture dislocation and complete paraplegic patient. We did right decompression and segmental posterior extension. You can see is lateral view during the 4-year follow-up and kyphosis, decrease of kyphosis. You can see decreases of kyphosis and hypokyphosis and lordosis develop during this follow-up period. And And third important point about traditional growing rod system. Traditional growing rod system with only proximal and distal anchor cannot provide sufficient correction on the main deformity, cannot control rotational and anterior growth, the main curve. Curve control is especially difficult in kyphoscoliosis. Now, we have a modified growing rod system to solve this problem. Now, I would like to describe our technique. We use intraoperative hollow femoral or manual traction. After skin and subcutaneous section, we place polyaxial secret into the strategic vertebra, that's mean apical and intermediate and transitional zone vertebra under fluoroscopy. And you can see we fix the most and proximal distal level. We leave the rest of top screw loose between proximal and distal level. And rod lengthening is performing at every 6 months. Advantages of this technique are not only proximal and distal screw, intermediate screw control the curve, prevent progression, maintain rotational stability without fusion, and there is no need to modify standard implant, there is no need of special instrument. Disadvantages of this technique includes radiation exposure to both surgeon and patient. Same skin incision is used every 6 months, and we have presented our result at the IMS meeting in Vancouver. Average number of lengthening operation was 5.5. Average coronal plane correction was 65%. Average truncal height increase was 30%. Now you can see some of our cases where syndromic scoliosis with the severe thoracic and lumbar curve, 2-year old male patient. We have performed our growing rod system. After fifth lengthening procedure, lumbar curve start to progress, and we extended growing rod system distally in this case, and you can see initial X-ray and last X-ray after 11 lengthening procedure. And the other syndromic case, upper thoracic kyphoscoliosis, very severe deformity. We have performed the same growing rod system, and you can see sagittal plane. We can control sagittal plane in this technique, and after we obtain coronal plane correction 70%, trunk height increase 11%, end of the fifth lengthening procedure. After fifth lengthening procedure, we did final posterior fusion in this case. And we recently changed our technique to sliding growing rod technique in order to increase the number of lengthening procedures. You can see sliding growing rod system. We fix most proximal 2 and most distal 2 level, and then you can see connection between proximal and distal rod, and with connector. Connector is fixed on the distal rod, is loose on the proximal rod, and you can see is a very severe congenital scoliosis. We have performed a standard growing rod technique, and then we changed with the sliding growing rod system. The other is very severe neuromuscular scoliosis, 6-year-old, 4-year-old male patient. And after a 9 lengthening procedure, we changed our standard growing rod to sliding growing rod system. Now is neurofibromatosis cases. We have performing sliding growing rod system, and is a Down syndrome with phallotetralogy. You can see is a pre- and post-operative X-ray, and we obtain a good coronary to brain correction with the sliding growing rod system. And 45 degree hepatic scoliosis cases, we are also performing sliding growing rod system. Our new treatment strategy provides CPRU in apical and intermediate vertebral control the curve, prevent the progression, maintain rotational stability, and allow continuity of trunk growth. Our sliding growing rod modification can be a solution to minimize multiple lengthening procedures. Depending on the size of child, it can be performed with any surgical or pediatric pedicle secure system. The use of allofemoral traction intraoperatively application at the initial surgery enables spontaneous correction of the deformity and the decreased need of forceful correction maneuver immature spine and prevent possible implant failures. Thank you for your attention.